Hi everybody, this is Shelly SRN, and I'm here to present to you hyper and hypoparathyroidism. We're going to go over labs, diagnostics, and medications for these disorders. Thank you so much for tuning in, and make sure that you log into my website, shellysrn.com, and take the quiz that goes with this video so that you can test your knowledge on what you learned today. Let's get started. First, we're going to go over hyperparathyroidism. Hyperparathyroidism has an excess secretion of PTH. So for labs and diagnostics, what you're going to see is an increased PTH and an increased calcium and a low vitamin D. This is for initial hyperparathyroidism. For secondary hyperparathyroidism, that's often the chronic kidney patients that have dialysis. They are going to have an increased PTH of 250 to 4,000 or more. Also, an increased calcium and increased phosphorus. Kidney patients on dialysis have a really hard time keeping their phosphorus down. You also have an increased creatinine, an increased BUN, and a decreased GFR. It's important to note that calcium should never be high, ever. And a lot of times, it's 100% telltale that increased calcium in the body, especially with an increased PTH, is indicative of a parathyroid tumor. Diagnostically, before you have a parathyroidectomy, you're going to have an X-ray or an ultrasound or maybe a cystamebi nuclear scan to visualize the parathyroid. As far as medications, the goal is to decrease the PTH, increase the calcium, and hydrate your patient. You're going to have IV fluids, normal saline, in order to hydrate and flush out the calcium. Also, Lasix, which will increase the flush and inhibit calcium reabsorption. We'll have to watch the potassium, that's very important, so we don't have cardiac changes. Also, there will be calcitonin, which is taken to decrease calcium release from the bones, and it increases the renal calcium excretion. So you want to stop it from getting out of the bones, and you want to encourage it to get out of the body through the urine. Biophosphates and calcium regulators. Fosamax is a very well-known one. It decreases the osteoclast, which is the bone loss, and it promotes the osteoblast, which helps build the bones back up. For secondary hyperparathyroidism, which is the kidney patients, you're going to have calcimimetics, such as Sensibar, which decreases the PTH, the calcium, and the phosphorus altogether. Moving on, we have hypoparathyroidism. Hypoparathyroidism is a low secretion of PTH. The labs and diagnostics you're going to see are going to be the opposite. We have a decreased calcium less than 8.5, decreased PTH less than 9, and an increase of phosphorus at 4.5. That increase is because the PTH helps to control the phosphorus. So without that, the phosphorus will increase. You may also have a low magnesium, which goes in conjunction with the low calcium, which is often seen in chronic alcoholism. Magnesium is very essential for optimal PTH secretion. So they kind of all go hand in hand to make everything go the way it's supposed to go. The doctor may order a CT of the brain and the neck to rule out any calcium deposits that might be occurring in those locations. Also, a UA calcium to rule out any excess secretions from the kidneys of calcium for an unknown reason that I don't know, but I could look up for you. Nextly, we have medications. The goal of medications is to increase the calcium and decrease the phosphorus. We have IV calcium, calcium glutamate, and you're going to want to give it slow and preferably in a central line so that you don't have sloughing in the peripheral. You're going to want to watch for cardiac changes and for ditch toxicity, as calcium glutamate can inhibit the digoxin secretion. Next, we have PO calcium with vitamin D preferably. Oscal with vitamin D is a good example. You're going to increase calcium absorption when the vitamin D is included. This medication may cause GI upsets, constipation, and renal calculi. Next, the phosphate binders, Tums and Phoslo. They're going to be taken with every meal because what they do is bind the phosphorus from the food that you eat and excrete it in the stool. Also, there's going to be PTH replacement. Natpara or Forteo are two examples. These medications are synthetic man-made parathyroid supplement, and they're going to be taken for the life of your patient, as well as the calcium and the vitamin D. You're going to watch for calcium overload so your patient doesn't get thrown into dysrhythmia. It's important to know that these medications, although they are meant to help increase the calcium, you're going to want to watch that calcium level so you don't have additional complications. And lastly is our vitamin D. It enhances the calcium uptake to help get the calcium into the bones, to help make the bones stronger so your patient doesn't have problems with osteoporosis in their life. Thank you so much, everybody. I hope you enjoyed my presentation, and please subscribe to my YouTube channel, Shelly SRN. Thank you.